So I think we need to start disseminating our research to much more wider groups. And in terms of how does the physio themselves use this information, I think there's some obligations when a parent comes to you and says, I want this done because my friend down the road, their child had this done and it worked. I think there's an obligation for that health practitioner to be informed. If we're talking about evidence-informed practice, they firstly need to know about this information before they ever are utilising it in practice.
All right, so I'd like to welcome onto the show. We have two fantastic colleagues here today with us on the Pediatric Manipulation Task Force. We have Nikki Milne. Nikki, did I say your name correctly? I don't even know if I know how to say your last name.
Yeah, us Aussies just shorten everything, right? So Milne.
Yeah. Milne, okay. We have Nikki Milne from Bond University all the way out in Australia. Anita and I are here on the Eastern time zone. Anita is coming to us from Canada. So this is great, able to get us all together for this podcast. I think a very important podcast on a project that all three of us were really a part of, but I really wanted to get Nikki and Anita onto this because they were really the lead. I think truly demonstrated a lot of the leadership in this podcast, and Anita certainly being the chair of the task force within that. Mm-hmm. So with all that being said, I'm going to let you all sort of give a little bit of a quick background about who you are, what you do, where you're at, that sort of thing. Maybe just a quick elevator pitch, and we've got about maybe 30 floors to get this done.
Okay.
And I'll let, I don't know, Nikki, why don't you go ahead first?
Okay. So I'm a pediatric physio by trade. I'm been doing that for about 23 years now here in Australia. I'm currently working at Bond University as a academic teaching pediatric physio and also researching. And I'm a member of the IOPTP, the International Organization of Physiotherapists in Pediatrics. I think, that it's been quite a while that we've been involved in the task force. So what brought me to this space was about 5 years ago, there was quite a big controversial stir up in the media here about babies having their necks manipulated, or their spines generally manipulated. And that actually resulted in an interim law being put in place in Australia to prohibit any health practitioners. And we only had 4 health practitioners who were approved to manipulate spines in the country anyway, they being physios, chiropractors, osteopaths, and medical practitioners. But the interim law prohibited infants' spines being manipulated because of the risks and some of the adverse effects that were being documented in the media actually at the time. So as a result of that, we had health practitioners, physios around the world contacting the member country organisations, the IFOMT, which is Anita will be able to tell you more about in a moment, and the IOPTP, asking what the profession's position on this is globally. And as a result of that, then a joint task force was formed from the IOPTP and the IFOMT, especially being more involved in spinal manipulation and mobilization as treatment modalities. And as a result of that, we all come together. So I was one of those members that started with the group, and along with Anita. And we've gone through over the last almost 5 years now of working about 4 and a bit years to get to the point of the position statement, and then starting to disseminate the findings from the position statement.
Yeah, I'm excited to get into a little bit of the background and nuts and bolts between this, because I know a lot of people have probably read these, and so that'll be great for us to get into. So Anita, I'm going to let you give us a little bit about your background and what got you into this task force.
Sure. My clinical background is orthopedic and musculoskeletal manipulative physiotherapy in Canada. Actually a graduate of Perth, from Perth in Curtin University as well. And I also have a component of my practice being pediatric population, primarily adolescents, but some children and occasional babies in the past. My academic background is clinical epidemiology biostatistics with the focus of research focus on neck pain. That has included a lot of work with Cochrane systematic reviews. And then Derek and I actually were involved in clinical practice guideline developments. That's where I got to know Derek. And then an interesting feature I was involved with was an adjudication of causation of adverse events following complementary and alternative medicine in pediatric populations with Dr. Anita Gross from University of Alberta. That was an interesting experience. And then being part of clinical trials as well. I became the chair of this after being asked by IFOMT, board of directors, and basically I jumped into it because I had clinical concerns, and I thought I didn't know what the best practice evidence was in this population, and so basically that was the key reason I was interested in accepting that position.
Well, I think everybody would agree that you were very well capable of being the person to be placed in the chair of this task force, and especially knowing you through other work, obviously having some clinical background and still being in the clinic, and then your background and work with Cochrane and other sorts of things. You were instrumental in really keeping everything going. And so certainly a bonus to have you as the lead on the task force there. So I'm going to get a little bit into the Pediatric Manipulation Task Force itself. Obviously you two are heavily involved. I guess talk to us a little bit about how everything else developed, because I know there's a bunch of papers that have come out and there's been different authors on certain papers and things of that nature. Talk to us a little bit about how that task force sort of grew, who became involved, and that sort of thing. And I don't know, I'll let either one of you take that question.
Go ahead, Nikki.
Okay. So the initial members of the task force, we thought it was really important to have a global representation on the task force. And obviously we can't have every member country of World Physiotherapy involved, but we did want to have some broad representation. So Anita was obviously our chair, has done an amazing job guiding the task force through a series of studies, which we can talk through in a moment, but also had Ken Olson from the US, who at the time was the president of, or soon just before that, the president of IFOM. Then myself, I was asked I was the member at large at the time on the executive committee of the IOPTP, and my president, because I had experience with systematic reviews and investigating the literature and some trials and some Delphi studies, she asked me to do that. And then we also had Annalie Basson from South Australia, from South Africa, and Jan Poel from the Netherlands. And we started with that group initially working on it, we really quickly realized that there wasn't a lot of literature on the topic, and that we were going to have to do or absolute findings already there for us to draw on. And so we knew we were going to have to work on synthesizing the evidence that existed and then do some further original research ourselves. So we brought on some students from McMaster University, from Bond University here, and we utilised them to help us do the grunt work through the reviews that we had undertaken. And then we got to a point where we knew we needed to survey much more broadly the profession, the physiotherapy profession. So the initial reviews that we did were interprofessional in nature. So we pretty much looked at the effectiveness and the adverse events from anybody, any professional who was manipulating the spine of infants, children, or adolescents in those reviews, and then also explored the outcome measures that we were seeing utilised in those reviews. But after that, we really wanted to know what the profession thought about this and where they were sitting, without having all of the results that we had just found and put together from the literature. And so we then knew we had to undertake a Delphi study, which is we undertook a 3-stage Delphi survey. And that meant that for each round of the surveys, the responses of one round of the surveys were informing the next development or the development of the next survey round, so that we got deeper and deeper into understanding the profession's position on it. So that happened, but we needed some more help at that point. And so we had Jennifer Dice, and at that point, Derek, you come on board as well. And then we also had Jean-Michel Brismy, and Jen and Jean-Michel had experience doing Delphi studies on this exact topic, but in the US. And so we thought they were a perfect fit, really, to bring on board with the task force and to help us expand those surveys out to an international audience. So that really made up our team of the task force.
And I think the final step, those were the first 2 dominant steps. And the final step was using that evidence to decision framework to chart any gaps once we've collected all that evidence. And to we spent a lot of hours, a lot of meetings doing a summative analysis from the systematic reviews, from the expert surveys to formulate what is now the task force recommendations. Just adding that piece.
So I think it's easy to say there was a lot that went into this project, many years and many sort of projects to what I would like to say, really generated recommendation statements based on about as good of work that you could do given the limitations and the evidence that was out there. I don't think that any stone was unearthed type thing. And so being a part of that project, I definitely got to experience that as well. And even then from I think we'll get into talking a little bit about the papers, but then also the other presentations, and then now the, trying to, having some sort of campaigns and things like that around it. I think it obviously is worth the output, because the effort and the input going into it was certainly extensive. So Nikki, you mentioned it's almost kind of like, I guess there's maybe 4 steps, but probably within 4 steps, there's probably 37 steps that were involved in this project. But, the first step you talked about was the scoping review. And I think that you really took leadership on that project there. And that's what you were talking about a little bit earlier. But do you want to expand on that a little bit in regards to, what did you end up discovering in that scoping review? This is where you talked about expanding it to all professions and all sorts of components there. Let us know what did you discover there?
Yeah, so I first started out by saying, because some people have asked us this question, why didn't you do a systematic review and meta-analysis? It was pretty obvious to us right from the beginning that there was not enough RCTs or clinical trials out there for us to be able to run a meta-analysis with the breadth of topics that we wanted to explore. We knew really quickly from looking at the literature, but also from our own clinical experiences, that spinal manipulation in particular, and sometimes mobilization, was being used to treat so many different conditions. And so, we in the physio world think about it from a musculoskeletal perspective, but other professions were using those techniques for a variety of different conditions, neurodevelopmental conditions, medical conditions, etc. So for that reason, we decided to undertake a scoping review and go really broad and make sure that we were completely understanding how these techniques were being utilized in practice and for what conditions they were exploring its use for. So we went to the research literature, and we had a look at the grey literature first to sort of come to those conclusions, and then we went into the research literature as well, and we ended up with 87 articles that we reviewed in total. And what we found as a result of that scoping review is that there was no evidence to explicitly support the effectiveness of spinal manipulation or mobilization for any condition in pediatric populations. So that's the first thing in terms of our major findings there. We also found that there were mild transient symptoms being displayed by infants, children, and adolescents in the randomized control trials. So those who were documenting adverse events, that was pretty common, that we were seeing things that, and when we say mild, we're talking about the papers essentially mostly considered mild adverse events if the families could resolve or supervise the child or the infant under their own care and that they didn't require medical attention to resolve the symptoms. And then we also saw some moderate to severe adverse events reported in the systematic reviews that were included in our scoping review. And, some of them were quite extreme. We're talking all the way through to death. So that we documented those adverse events. We found that there was strong to very strong evidence of no significant effect of spinal manipulation for the management of asthma, in particular pulmonary function as one of the impairments, for headache or nocturnal enuresis, and there was inconclusive or insufficient evidence of all other conditions that we explored. So there was just, real scarcity of research out there about a lot of topics that we knew in clinical practice the techniques were being used for. And there is insufficient evidence to draw conclusions regarding spinal mobilization to treat pediatric populations with any condition. And that kind of shocked me because I think that probably is used even more than spinal manipulation. And there is just like a complete gap in the scientific literature in that space. There's very little research to support or, give us any strong beliefs about what we should and shouldn't be doing in that space with mobilization. Yeah, so those are the main findings from the scoping review.
And then from that, we kind of took the next step would be the 2 clinometric reviews that we did do. We determined from that scoping review which outcomes were the primary reported outcomes, and then did a search specifically for those outcomes. Those are we identified as clinical outcome assessments, and we divided them into 3 categories: the patient-reported outcomes, the clinician-reported outcomes, the observer-reported outcomes, and the performance-based outcomes, and did a massive systematic review. And we have to give credit to Tricia Hayton for the huge amount of work that she did in that regard. We just determined that there were in each category about 2 or 3 outcomes that were of fair value, and then just about 2 outcomes that were of highest quality, one of which was the AIMS outcome, Alberta Infant Motor Scale, and I believe the latch tool was valuable as well. That's the latch stands for latch, audible, swallowing type of nipple, and comfort and hold. You think, why are we looking for that? But there was a lot of for sucking, for infants having difficulty latching on in their infancy to nurse was one of the problems, right? And
yes, and that really shocked me when we were seeing that in the literature. I was like, using these techniques for that? It was quite hard to try and understand the rationale behind using those techniques for those reasons. Yeah.
And so, Anita, as you continue on there, I just want to interrupt you just because I wanted our listeners to know these are outcomes specific to pediatric population, right? Yeah. So that's where, and so a pretty exhaustive potential list of outcomes that could be used. Okay.
Yeah. And in any case, there is, even across all of these, we determined that there's probably 2 main outcomes. I believe it was the Alberta Motor Scale, and I think the scoliosis quality of life questionnaire was fairly strong too. But that led us to
good. So now you have the all of the evidence that you could potentially find in as good of a search strategy way that you could do. And having Anita on the team, being a Cochrane reviewer, I have full faith that those search strategies would pick up all of the identified literature. So there's the evidence, where it stands for pediatric manipulation mobilization that Nikki talked about. And then on the other hand, now we have outcome measures associated with that could be utilized to determine, I guess, effectiveness if there was something out there. So now we have those kind of two ends of that. And so from there, where did you feel like you landed at, I guess, with the information? Because some could argue that, well, since you didn't find any evidence out there, couldn't you make your recommendation statements off of, the limitations in evidence? And, could you make some of the recommendation statements there? Where did you find yourselves at that point in time? And then where you felt like you needed to go next with the project?
I think it was, well, I won't answer it all, but you can jump in at any point. I think it became clear to us we needed that expert Delphi survey methodology integrated into this to get a clinical expert perspective, because we had so many gaps from a research perspective. We weren't, as a task force, just going to jump in and fill in gaps. We wanted to know what the international perspective was on it, and that's where Jen took and Jean-Michel took us to developing a really exciting expert Delphi survey, I think.
Yeah, I think it was a challenge to get the expert panel. So we ended up with 26 international experts. It was a challenge to get that panel right, I think. So we spent quite a lot of time trying to make sure that we were finding out who's possibly the right fit there. And the reason for that is that there's kind of two camps here who are impacted in terms of physiotherapists. One is the, musculoskeletal, manipulative, manual therapists. And then there's the pediatric therapists, because the population are pediatric groups. And initially, when we started putting our feelers out to try and find experts and get recommendations on experts around the world, there was the pediatric world going, well, we don't do this, so this is not relevant to us, but we do want to understand it because a lot of our clients are having this done. And so they were interested, but, it was hard to find experts in that space. And then there was the manual therapists who might be doing it, but not necessarily with the breadth of pediatric populations. And so they also felt like, oh, I'm not quite sure if I'm the right fit. And so there are a lot of people who ummed and ahed. And so it took us some time. We had to spend a fair bit of time making sure we got that balance right, and that we had the right mix of experts to be able to make expert decisions at the end and come to consensus.
Yeah, I think that's a really good point to bring up. And I'm glad you brought that up, Nikki, because it is hard to find the expert that is treating, that's performing or has the ability to perform spinal mobilization manipulation, treating a pediatric population. And I remember being part of that and us struggling to really find that type of an individual who is managing those situations. And across, like you said, even the breadth of just beyond a adolescent with back pain, we really wanted to get, sort of all potential areas represented, so that way when they were able to address those items, they could actually do that.
Yeah, there was
a good group. Yeah,
there was a call out through IFOMT, through the IFOMT members, and each of the country members really did a major search in their countries. So it truly was an international effort to find the best people for that expert Delphi survey from across. I don't know how many groups are in IFOMT now, 26 or 27. I forgot.
I think you've got 36 maybe.
Sure. Yeah. You know more about it than that's not good.
Nevertheless, we we got quite a group together. It even coming up with the survey question was a fair degree of a challenge. It was that 2-part, as Nikki already identified, and then I think it was a challenge for the experts to fill in the survey because it was pretty extensive. So one of those particularly long surveys that once you get started, you really have to spend the time and think time to get through it as well. So, congratulations to those experts for finishing all that.
Yeah, anytime I get a Delphi invitation, I'm more apt to participate because I do know the process behind it is very grueling. So, because what did with the Delphi study, I think that's probably one of the areas that a lot of clinicians are probably interested in, and with regards to the results of that, what were some of the things that you were, I guess, maybe either surprised about, or you kind of, were consistent with some of the thoughts that you had, but what were, with regards to the outcome of the Delphi study, what I guess, what were some of the findings and what were the biggest surprises, I guess, if you will?
Yeah, I'm happy to talk to that. We've got, I guess we were looking at it with really keen interest, knowing the results of the scoping review and the systematic reviews that we'd undertaken on the outcome measures. So, as those results come back in after they have been analysed by the analysis team, we saw that the first big outcome, I would say, of that Delphi was that the profession said for infants across all conditions, impairments and spinal levels that manipulation shouldn't be recommended. So that was immediately consistent with what we had sort of come to terms with from the literature reviews. Secondly, that for children and adolescents across most conditions and spinal levels, that they thought manipulation should not be recommended. And then that manipulation shouldn't be recommended, may be recommended, for adolescents to treat spinal region pain, joint hypomobilities at the thoracic and lumbar level to manage pain in the thoracic system level. So there was that. And then for mobilization, they said it could be recommended, spinal mobilization recommended for children and adolescents with hypomobility, joint pain, muscle myofascial pain, or stiffness at all spinal levels. So a bit more accepting more broadly of the profession was much more accepting of utilizing mobilization than manipulation with pediatric populations, which is kind of what we expected, I think. We were seeing that utilised a lot more in the profession, and I guess that none of that really shocked me. Probably the one thing that shocked me in the analysis was some tolerance that we were seeing for utilising spinal manipulation and mobilisation for some neurodevelopmental conditions, and so that it didn't end up consensus to use it. So that wasn't the outcome of our results, but we saw the results swing a little bit more in terms of the tolerance for utilising these techniques for those conditions. That shocked me because I couldn't understand I couldn't clinically reason why that we would use these techniques for those conditions. So,
And so that was step 3 of the project, which again, you have. And this is where I think, Anita, your expertise, especially in guidelines and, interpreting Cochrane reviews and things of that nature, what I guess impressed me most was sort of this final stage where we went on to make the recommendation statements. And I'm sure, Anita, it was probably the best time of your life sitting through and trying to figure it all out. But, I being a part of that, I certainly got to understand that. But I think it's worth, because we came up with some pretty big recommendation statements, right? We came up with some pretty profound recommendation statements that may be aligning with clinicians, and then the recommendation statements may not actually align with clinicians. But I think it's really important for us to discuss, or for you to discuss, maybe, Anita, the process that went into making those recommendation statements. And this is sort of that step 4, if you will, of the project, where you were using the evidence and the decision framework and the Delphi information to thereby then create those recommendation statements. Do you want to expand upon that if it doesn't haunt you too much?
Yeah, if I can. Yeah, we utilized a newer model that I kind of consulted here at McMaster University with some of the experts on how to get some of this information together. And we utilized the evidence to decision framework to try to chart out the gaps in the literature between what Nikki's students had come across from or determined from the scoping review and what was identified in the Delphi review, and then trying to get uh, shuffle the two together in order to get a summary analysis for that. Uh, and that took us a fair amount of time, disorder by disorder, week by week. We spent a lot of hours and time and Zoom time, I suppose, to gather that information from this, melding the systematic reviews and the expert survey from the task force to come up with the recommendations. But I think we came up with some pretty solid recommendations at the end. Um, I, I'd like to jump into kind of identifying them if I can, if
Yeah, go ahead. Yeah.
ones. So I kind of divide this into the good news group and the cautionary kind of safeguard kind of group. So the safeguard group was that spinal manipulation and mobilization should not be performed on infants. That was a huge consensus, and should not be performed to treat non-musculoskeletal pediatric conditions in infants, in children, and in adolescents. Uh, and neck and low back manipulation should not be performed on children. So those are the two safeguard kind of huge statements. And then,
Anita, can I just add to that in terms of the non-musculoskeletal conditions, just so that for those people who are listening to this podcast and may not be familiar with what conditions we're talking about there, they're things like asthma, ADHD, autism spectrum disorder, the breastfeeding difficulties that Anita spoke about before, cerebral palsy, infantile colic, nocturnal enuresis, and otitis media, ear issues. So they're the kind of things that we were looking at that were the non-musculoskeletal conditions.
and the typical musculoskeletal conditions of low back pain or neck pain, things like that. The good news is that spinal manipulation and mobilization may be appropriate to treat true musculoskeletal conditions. That would be related to spinal pain or headaches from spinal pain, but not headaches in general, but emanating from the cervical region. I don't know if
Yeah.
I think those two categories are the dominant results.
Yeah, and I
And I
just want
just
to reiterate that if you, I think maybe we'll either have links or something along the lines, but the papers that, especially this paper that the recommendation statements were made from, I think really describes the methodology really well. It's very complicated and complex, and when we looked at all of the recommendation statements, there was a systematic approach to making those recommendations based off of the scoping review, based off of the clinometrics, based off of the Delphi, and then based off of the assemblance of all of us together to create these recommendations. It wasn't willy-nilly. It wasn't based on, something that was just as one aspect of research. I think that's the thing that I think is that the greatest accomplishment of this task force was just the amount of depth that went into making these very, profound but very deliberate recommendations, especially when there is limited evidence associated with it.
I think too, Derek, it's important, I think, for whoever's listening to this to know that that wasn't an easy process. Those discussions that happened at the end were really robust. There was a lot of checking of biases, our own internal biases, because we all have them. Whether we're for something or against something or believe in something because we've seen something happen in the past, or so we constantly were challenging each other's biases during those conversations. And as soon as one bias inadvertently was displayed, you had 4 or 5 other task force members saying, is that because you've seen that? Or is that because of the evidence in front of us? So there was really a very rigorous process to just keep us on track, following the process that Anita had put in place and not allowing us to deviate with any personal bias off that.
Yeah, I think that's a great thing to bring up, because I felt it when we were going through the recommendation statements that, well, but what about? It was like, no, we had to go back to the science there. So to that end, the project is kind of over, but it's not really. I think it's going to live in perpetuity for a little while or something. But where do you see sort of these next steps? Because I think that there's still probably gaps, if you will, in certain areas. But what do you think are some of the things that need to go on next from this chapter of this Pediatric Development Task Force, or what do you hope to see comes down the line because of the work that you all have done?
You can go ahead with the adverse events ideas that you've had.
Yeah, so a few things. I think dissemination of these findings is still really important. If you look at the evidence around how long it takes to translate research findings into practice, it's a long-term process. It's not quick. And, we have so much more things like social media at our fingertips now to push messages out very fast, but it still doesn't reach everybody. Not everybody in the world has those resources. So we're working on the dissemination documents that we've got around these key position statements. We're doing some translations into some other countries at the request of a lot of the member countries. We are trying to ensure they go out. We're doing things like these, the podcasts and webinars, to make sure that we're reaching both the manual therapy community as well as the pediatric community who see this through different lenses. So we're doing those things. And then a couple of things came out of the findings, and that is that there's just not enough research about these topics. So our profession thinks, well, maybe these things might work, and they've agreed that they may be appropriate, even though we don't have good scientific evidence to support those statements. And we've been clear about that there is no high-level evidence to support any of these practices. But we have the profession going, well, actually, I'm seeing it in practice and it is working quite well and I'm not getting adverse events. And so we're hearing that, and we know that more research needs to be done in those areas where there are not massive adverse events being documented. But we also know that the adverse events are not being reported very well at all. So a lot of the literature that we went through in those scoping reviews and in reviewing the literature generally, was a lot of them didn't even mention the word adverse events and any negative outcomes. So they weren't necessarily being transparent about those. And we know that most countries around the world don't have any compulsory reporting about adverse events for these techniques either. And that's a big issue that I think the task force has talked a lot about, and thinking, how do we tackle this one? Because this is multi, governmental policies, etc., that are surrounding this issue. So one of the things that we've talked about for some future research is trying to get some large emergency departments on board for doing some reporting of the clients that come in with adverse events after spinal manipulation or mobilization, because we're hearing anecdotally that our emergency physicians or our emergency physiotherapists are seeing these patients come and present into the emergency department after manipulation or mobilization, mostly manipulation. So we want to start documenting that evidence because it's not out there for us to digest. So that's one of our projects. The other one is there is some opportunity, and these projects are underway as well with members of the Spinal Task Force, to start doing some meta-analyses on little pockets of research within or topics, conditions within the scoping review that we did. So for most of them, there's just not enough literature to do that. But the occasional ones, like the use of manipulation for headache, for example, there's a little bit more literature there that we can pick up on and try and run our meta-analyses with that. So those studies are also underway.
That's exciting. Very exciting.
Yeah, I just wanted to add too, from my experience in adjudicating causation of some adverse events from complementary and alternative medicine. Some of that was on manipulation of pediatrics at that time. But even pediatricians don't do reporting very well. And this was mandatory reporting by pediatricians from across America, actually, not Canada, but America. And it was really not much reporting. So I think the ER idea that Nikki had brought forward to the team was an essential one, in getting multiple different centers around the world involved. And that would be a really new approach to getting adverse events and detailing around adverse events, maybe not the ones that completely kill the infant, but the ones that cause serious enough adverse effects that worry a parent to bring the child in to the ER department. And even if it wasn't a devastating effect, those are important adverse events as well. The other thing that I had wanted to identify is that the knowledge to add to, even though we did tons and tons of stuff on knowledge translation, like 7 publications, the policy brief, a number of Instagram posts that and reels on social media. One of the big things is I don't know what the uptake is, even if I have no idea what the uptake is. And I know even in Canada, we don't have that. The standard physiotherapist across Canada does not know about our information, even though we push out social media information. So there's a huge research piece there, as Nikki had identified as well, on just getting that information out. And the last piece was, what's the decisional need from the actual patient, not just patient, the parents that are dealing with choosing manipulation. Is there a decisional need from them? And that's an important question as well that Derek and I have started looking at as well, along with some other team members in Canada. So a lot of
and
tentacles
so
going out.
Yeah, lots of little side projects. So the Pediatric Manipulation Task Force lives in perpetuity and continues to grow, which is great because that's actually one of the calls, is to expand the research in this area. And so it's kudos to everybody that's staying on and continuing to push this information forward, as opposed to just keeping with the guidelines there. I guess I had one other question too, though. Like you said, Anita, and just this just triggered my thought here. We mentioned this to, obviously, our clinicians and our clinician colleagues, especially physical therapists and such, but so much of the decision is made by the parents, and there's so much lack of information around that. Is there any sort of efforts at all in regards to, and maybe this is, much farther downstream, but, providing information to parents and parent groups and those sorts of things at all? I don't know if that's been something that you've considered.
Yeah, for sure. We've looked at the trying to find where are the pods of parent groups that we need to consider and we need to get information out to through social media approaches. We have Instagram posts and all that, but I think they quickly stop if we don't get them into the right parent groups. I don't know that we've discovered who they are, but we've had lots of brainstorms as to who they could be. Nikki, I don't know if you have anything to add to that.
Yeah, I think so. We've talked about not just needing to disseminate to the profession our findings, but to also get it out to people who care for children. So to parents, to childcare centres, to schools, because I'm seeing here locally on the Gold Coast where I live that children are coming home from daycare with information about health professionals being able to manipulate your spine to help with your autism, and they can manipulate your parent as well to help with this bonding relationship. So those kind of statements are really unfounded in terms of having any evidence behind them. We now know from all of the work that we've done. So I think we need to start disseminating our research to much more wider groups. And in terms of how does the physio themselves use this information, I think there's some obligations when a parent comes to you and says, I want this done because my friend down the road, their child had this done and it worked. I think there's an obligation for that health practitioner to be informed. If we're talking about evidence-informed practice, they firstly need to know about this information before they ever are utilising it in practice. And then they need to be able to share that information in a family-centred approach to care. So first, find out what the family, whoever's presenting with the child, what do they know about this treatment modality already? And they're probably going to know about what they believe to be beneficial effects. They probably don't know about adverse events. And we have a responsibility to tell them there's risks associated with this. And we don't know the extent of those risks, but we know that they're there. And so we can share what we already know from these papers. It's all documented in the papers. So firstly, shared decision-making. Yes, find out what they want and what their goals are, and make sure we give them the evidence that exists in a digestible way for that family or that child, depending on their age. It could be an adolescent, and you can sort of talk to them more directly. Make sure they give their assent and the parent gives consent after they've got all of that information. And then I think we can truly say that we're providing evidence-informed practice. But without family-centred practice, without shared decision-making, and without that sort of ethical code of making sure that the parents know the evidence behind these interventions and the potential risks, then I'm not sure that we're doing the best by them.
Yeah, I appreciate that. And it's similar to at least here in the United States, I feel like every time I turn on TV, it's a pharmaceutical commercial, basically equipping the patient with the information, right? And that's actually a little bit about how this is actually working in some regards. Like you said, in those daycare centers, people are equipping them with information, but is it the right information? Is it misinformation? Is it disinformation? As opposed to real information? And obviously that's a hard thing to battle, especially on shoestring budgets for getting information out and such like that. So, but hopefully that's something that gets out there, and hopefully clinicians can speak to it. We're getting a little bit close on our time. I didn't want to take us too long, but I think this is a really important topic. But I'm going to give each of you both you get sort of one parting shot, if you will. So one key takeaway you would like the listeners to gain from this podcast.
Do you want to go first, Anita?
Yeah, I'll say that one of my greatest surprises from working with this team is the immediate impact and the timely impact that we had on government policy in Australia within 3 days of our publication. I think having this team's work get pulled into a real policy is the essential and best way to push it out there. And what happened is an infant spinal manipulation ban was reinstated by the Australian government very close to after we've produced our publication. And I thought that impact was amazing. So I think that was one of the best outputs, but it only hit one country as such, right? So that had a massive impact, I thought.
Pretty important country to hit.
Yeah, I'm biased, so I'll say yes. It was an important country, but it was really cool actually, because it ignited in the media again very quickly as one of our health professions decided to self-regulate and start manipulating the spines of infants again. And so our political bodies asked for please explain. And then they reached out to all the professions who are licensed to manipulate spines and asked for input. And the physiotherapy profession were able to quickly pick this up and utilize it. The medical practitioner community were able to utilize it as well, and then have that direct impact. But my one, parting shot is don't manipulate the spines of infants. That's what I would say. I guess they're the most vulnerable population. They're so tiny. There's a lot of evidence-based practice that exists around them for a lot of the conditions that the babies present with. And
not just don't manipulate, don't mobilize as well.
Yeah.
Both.
Yeah.
And that was something that came out within the scoping review, came out with all aspects of it. That was probably one of the easier recommendations we were able to make off of that. So
Full consensus.
Full consensus there on that. Well, I want to thank you both for taking time out of your, morning or your evening, depending on where you were at. And other than that, I look forward to getting this podcast out there, and hopefully everybody gets to appreciate the breadth and the depth that went into this work. And if you're listening to this podcast, certainly go to the papers that are available. A lot of them came through the JMMT. Fortunately, we had Jean-Michel as the editor there, was able to get us aware that there was going to be a pediatric specific issue, and a lot of these papers landed in there nicely. So, but thank you again, Anita and Nikki.